From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello and welcome to our listeners around the world. You're listening to JAMA Author Interviews. I'm Dr. Christopher Muth, Deputy Editor at JAMA, and I'm here today with Dr. Julie Bynum, who's the Margaret Turpenning Professor of Medicine in the Division of Geriatric Medicine, Research Professor in the Institute of Gerontology, and a member of the Institute for Healthcare Policy and Innovation at the University of Michigan. Today we'll be discussing two related original research articles published in JAMA. These articles report the results of two randomized clinical trials, the D-CARE and IN-PEACE trials, which were studies of collaborative care models for patients with dementia. Dr. Bynum was also the author of an editorial published in JAMA that accompanied these two articles. Thank you for joining us today, Dr. Bynum.
Thank you for having me. Delighted to be here.
To begin with, can you explain what exactly are collaborative care models for patients with dementia?
Dementia care is a really complex endeavor when you're handling people who have a lot of medical problems, as well as a lot of need for social care, like caregiving and community resources. So collaborative models are meant to really draw all of those services together to try to give a more person-centered experience to the person living with dementia and to their family and care partners who are really trying to navigate this complex system of medical and social care.
Have collaborative care models been developed and studied before in prior research?
Yes, absolutely. There are a number of interventions and trials that have been done over the last many years, 15 years in particular, where investigators have designed different strategies to be able to expand what mostly primary care doctors can do by linking in either community health workers or nurse practitioners or other kinds of care supporters to the caregivers into the medical system to help people move forward. So yeah, there is a body of work here that have shown benefits for people in various stages of disease.
And why do you think more trials are important, like the ones we'll be talking about today that were published in JAMA?
Well, first and foremost, the population of people with dementia is growing. And it's purely a product of aging of the population. We're going to have a very high proportion of our population who have this disease as we get older, as the whole population gets older. So we need really good ways to help people live with this disease in our communities. Along with that, there's really incredibly high costs, financial costs to both the individuals and families as they try to navigate chronic conditions, as well as the need for, say, in-home caregivers or nursing homes. And it's also a really devastating disease for people to live with and for their families. So we haven't had great strategies to handle the needs of people in communities until the last couple of years we're developing these models. There also haven't been drugs to treat the disease. There are new drugs to the market that are raising hope that someday we will have drugs that make a substantial difference in the symptoms of the disease or even modify its course. But those really aren't ready for prime time and going to impact people who already have the disease. So we do need evidence-based approaches that can really help people out in real practice, not just in specialty clinics, manage living with this disease, both the social and medical problems that it really brings forward.
Yes. And there's also a relatively new CMS, alternative payment model. Is that right? Called the GUIDE model that is going to be looking at these types of care delivery programs.
Absolutely. The GUIDE model, which stands for Guiding an Improved Dementia Experience, is actually an alternative payment model that's been released by the Center for Medicaid Innovation. And really, that's the product of the fact that there are clinical trials that have been successful in reducing some of the impacts of this disease. And those trials were tested for their payment methodology as well through CMMI and have now advanced to the stage of being an alternative payment model. What that means is that at this point, provider groups, physician groups, or community organizations can actually apply to participate in this alternative payment model, which will provide funding to support some of the services that are not traditionally paid under Medicare. So this is another driving force of why it's so critical for us to have a good sense of what works and what doesn't work as we start to expand these services across the whole United States and try to increase access.
Exactly. And so I think that's the background in my mind about why these studies are important. So let's turn to the two studies that are being published in JAMA, the D-CARE and In-Peace trials. Let's talk about the D-CARE study first. This study enrolled over 2,000 patient caregiver dyads from 4 health centers, and they were randomized 7 to 1 to either a health system-based intervention that was delivered by nurse practitioners or physician assistants who were essentially working within the healthcare system and can write orders, communicate through the electronic health record, or they were randomized to a community-based model that used telephone outreach delivered by nurses or social workers within community-based organizations, or they were randomized to usual care. And the primary outcome for patients was the severity of the neuropsychiatric inventory questionnaire, and the primary caregiver outcome was the modified caregiver strain index, and these were assessed over the course of 18 months. And then there were other secondary outcomes focused on caregivers. Can you tell us what were the main top-line findings from the study and what you thought was important from this study?
Yeah, happy to. Just stepping back a little, there's a lot of details that you just relayed, but in the big picture, what this study was doing was it was a pragmatic trial, so designed to be implemented at scale. And it was comparing 2 previously tested approaches, this health system-based approach and the one that is more directed toward the caregiver directly with some interaction with the health system versus usual care. So it was really meant to be almost a comparative effectiveness study. Unfortunately, the findings were null on the primary outcomes of the neuropsychiatric symptoms, as well as another measure related to that on the caregiver. And that's really a disappointment. Interestingly, there was no difference between either of the intervention arms with usual care or between the intervention arms. But there's a lot to say about why they had those findings or why they may have had those findings. I think that we should discuss a lot more as we think more about this study.
Okay, yes. And do you have any other thoughts about that study?
Yeah, happy to say more. First of all, we're all really disappointed, right, to see this primary outcome not be positive for interventions that have been shown to be beneficial over time. And there's a couple reasons why maybe we didn't, and a couple that I really want to highlight. First is that some of these outcomes, when you look at them closely, have really wide confidence intervals. And you mentioned this randomization strategy of 7 to 1, which meant there were fewer than 200 people in the usual care arm compared to 1,000 in each of the intervention arms. So I think that probably impacted their ability to detect a difference between usual care. Because personally, I'd be really happy to see either of these arms be better than usual care. And that's sort of the important takeaway. That said, it also found that even though while still non-significant, for some of these outcomes in subgroups of people, the point estimate, while not significant, was in the direction of potential benefit. So we have perhaps a sample size issue for the usual care, because frankly, what I really want to see is difference from usual care, because I'm very happy for either of these interventions to work. The second thing, the subgroups. And the third thing we really need to call out is both of these interventions happened during the COVID-19 pandemic. And that clearly, as we all know, had tremendous impacts on everyone. But people living with dementia and their families, this was especially profound. So first, these people with dementia have complex medical needs. You have a higher burden of comorbid illness than many other groups, and they had less access to their medical care. And you could imagine navigating virtual care might be challenging for somebody who has cognitive impairment if they don't have a care partner. Secondly, the ability to get in-home caregivers and access nursing facilities and all the other kinds of supports in the community was severely restricted. So we might guess that it would be difficult for any trial to have benefits in the context of COVID-19. So I think those combinations make me feel like the deck might have been not in a positive direction for this trial or in peace, which also happened during COVID-19.
Yeah, that's very important context, I think. And so now to talk about the NP study a little bit. This was a smaller study, about 200 patient caregiver dyads from 2 health systems in Indianapolis. Some of the unique things about this study, I thought, were the patients had either moderate or severe dementia and were living in the community. And the participants were randomized to either usual care, which was basic informational materials, or the intervention, which was monthly phone calls from a care coordinator and assistance navigating the health system with evidence-based protocols. They also had an emphasis on palliative care education and principles. And here, the primary outcome was the same as it was for the D-Care for patients, the severity of neuropsychiatric symptoms. And they had 4 secondary outcomes, including ED visits and hospitalizations assessed over 24 months. And can you tell us here what the main findings of the study were?
Yeah, this study was conducted at Indianapolis, which was the origin institution for many of these dementia care coordination models. So it's in the background of an institution that's been doing this kind of work for a while. So it's not as far down the path as the D-Care study was, which was much more pragmatic and about scalable interventions. And the real added piece to this was really focusing on those issues of palliative care and adding modules around palliative care for dementia. Their findings with their primary outcome, the neuropsychiatric measure, was null, also a negative study, but they did find benefits for emergency department and hospitalizations, and it was a substantial size effect for that. It also, similar to D-Care, showed even more benefit among subgroups of people. So how I take this study in partnership with the D-Care study, I think it actually reinforces some of the things I said about the D-Care, that they are focusing on people at late stage with more just by the nature of the trial, and they are seeing some benefits there, whereas D-Care took all comers with any diagnosis of dementia with no delineation by stage or severity of symptoms. So we're seeing some more positive effects for the more focused study, and it showed some of the same subgroup differences, like I mentioned earlier.
Yes, so there may be some benefit depending on which outcome you're looking at and perhaps which subgroups. I think that's another interesting point that I think the authors themselves raised as well, which is you're comparing these interventions versus usual care when the usual care at these institutions may already be quite robust and high quality care for patients with dementia. And then depending also on which outcomes you're looking at, you may not be able to see an effect in neuropsychiatric symptoms, for example, if there isn't a high burden of symptoms at baseline.
Yeah, I think it's worth talking about that as their choice of a primary outcome, the neuropsychiatric symptoms a little bit, for people who are maybe less familiar with dementia care. So the neuropsychiatric inventory measures things like aggression and psychotic symptoms and those sorts of things. And that's certainly a part of dementia. It's usually associated with later stage dementia, and certainly not everybody has it. I think that's important, and the authors in both studies point this out, that the choice of that as primary outcome, D-Care had an additional co-primary outcome, may really influence also the null outcome, because certainly not, particularly in D-Care, where you may be picking up people at earlier stage, this symptom may not be very prevalent. And I actually wondered, does it make sense to use a symptom that arises as disease progresses for an intervention that doesn't alter the trajectory of the disease? So, the example I would give, you wouldn't expect a care management intervention to alter the course of the progression of a cancer, for example. So I'm not sure, if we use that analogy, I'm not sure that's appropriate, but is that really the most likely measure to show us that these interventions are working for people? But admittedly, it's really hard to measure patient-oriented and person-centered measures, quality of life, decreased symptomatology. That's actually extremely challenging in all diseases. And just imagine that in the case of dementia, where you have cognitively impaired subjects who have issues with symptom reporting and their hardworking care partners.
Yeah, I think those are great points. So where do we go from here? And what do you make of these findings and putting them in context with the guide model and care for people with dementia and their caregivers?
Where do we go from here? Great question. I'm not ready to throw the baby out with the bathwater, right? I think there's enough reasons for us to say that these trials didn't show a positive effect, but there's enough on the main outcomes. But there was enough else going on and some other signals from the study that I think we should still debrief where we are from these studies and continue to move forward. And especially in the context of the rollout of the guide model, it puts additional emphasis on the absolute critical nature of evaluating what's going on in the places that are implementing these models. They have a financial incentive to do it through the payment model itself, but they don't have strict instructions on how to do it. There are several components that they have to do, which are around providing 24/7 dementia support, respite care, access to expert interdisciplinary teams, and training for the care partners, but they can deploy it any way they want using whatever materials. So one of the keys, I think, moving forward is seeing what health systems do and really hoping and pushing them to be learning health systems, to study what they do. Let's not just rely on the overarching CMMI evaluation, which will evaluate the program in total, but let's try to get some energy around understanding what's going on in each individual practice and what's working. Because, to be honest, I think sometimes localized health systems, they know their service needs and communities better than us who sit designing trials that get deployed across multiple places. And so I think those insights are going to be critical to move forward.
Really great points. Is there anything else that you want to add about these studies or about anything else?
I can't stress enough how incredibly challenging it is to make the lives of someone who's living with the disease and their family or care partners better. It's a really, really challenging condition to manage. And in addition to that, it's very common. So unlike, there's other diseases that are like this. You might think of people who have developmental disabilities or other really serious medical conditions like cystic fibrosis who need lots of care, or ALS, for example. The trick with dementia is that it's also so common in such a large population. So this is going to have to work in primary care. We're going to have to figure this out so that we can really get access, because this isn't going away for any time soon. And I applaud the investigators and the people who participated in this trial really making the effort to make the care of people living with this disease better. And we really just can't stop now.
Yeah, I agree. These are very important contributions to the field and definitely things to build on. Thank you very much, Dr. Bynum. I'm Dr. Christopher Muth, and I've been speaking with Dr. Julie Bynum about collaborative care models for patients with dementia. You can find a link to the articles in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.